Hi, my name is Carolyn Vandyken, and I'm going to talk to you today about a consideration of a biopsychosocial framework for overactive bladder and bladder pain syndrome. I have no conflict of interest to declare. Before I start, I'd like to thank Sue Croft and the organization committee for inviting me to come and speak today. I'd also like to thank Rosa for her fabulous administrative assistance in coordinating this talk from halfway around the world. And I'd like to thank Trishan and Judith for extraordinary friendships and collaboration with bringing a biopsychosocial framework to pelvic health physiotherapists in Australia. First of all, I'm a Canadian, which means I like to say a lot. I'm a registered physiotherapist with a MUSC background, pelvic health background, and pain science background. I'm a clinician, researcher, and educator. I'm passionate about all things biopsychosocial. I've published a dozen research papers, framework articles, and position papers on my three favorite topics: pelvic health, pain science, and chronic low back pain. As well, I've co-authored 4 chapters in textbooks on persistent pain and pelvic health. I like to think outside the box and put ideas together from different areas of specialization. So we're going to start by examining the proposition put forward by Reynolds et al. In 2016 that asks the question, does central sensitization help explain idiopathic overactive bladder? This fits my bias since I have been treating overactive bladder as a condition highly connected to the central nervous system for the past 7 or 8 years with great success clinically. We know that bladder pain syndrome has been identified for some time now as a condition associated with central sensitization. This guideline of guidelines is a great attempt at aligning international terminology. However, I would like to point out that there is still not international agreement on terminology regarding bladder pain syndrome and interstitial cystitis. Where overactive bladder fits on the spectrum is also under great debate. I had the great privilege of attending the 2015 ESSEC conference in Rome on IC bladder pain syndrome, which led to much more clarity for me. I was really impressed with this medical organization who were early adopters of understanding the role of central sensitization in bladder pain syndrome, IC, and overactive bladder. These 3 syndromes have very similar presentations, and to further muddy the waters, we could add the male version of these urological pain syndromes to the mix, which of course is non-bacterial chronic prostatitis. Based on everything that I have learned and gleaned from conferences and papers, I look at these syndromes in the following way. They all share common reported symptoms, including urgency, frequency, and nocturia. Bladder pain syndrome and IC both report pain on bladder filling, which may be temporarily relieved by voiding. What distinguishes IC from bladder pain syndrome is the presence of Hunner's lesions on cystoscopy. On the other hand, overactive bladder patients report excessive pressure or urge on filling, and they void to relieve this pressure instead of pain. However, recent research has shown that 40% of women will report this pressure as painful. Hence the confusion and lack of clarity. We will see that also in the case study that I present today. My case study was diagnosed with IC, but in reality presented with more OAB symptoms if we use the classification system I just described. If we're going to examine the question, does central sensitization help explain idiopathic overactive bladder, then we should first understand what central sensitization is. Central sensitization is defined as the amplification of nerve signals within the central nervous system, which elicits pain hypersensitivity. Since pain is not usually reported in OAB, does the presence of urgency fit with this classification system? Let's look at this more carefully. The MAP research program has certainly been able to demonstrate over the past decade that urological pelvic pain syndromes are highly correlated to structural and functional changes in the central nervous system. Pain is an output of the brain, but so is urge an output of the brain. Based on significant central processing, it is your brain that decides whether or not to produce an urge sensation to get your attention in order to make sure that you find the toilet. However, you should have enough adaptability within your central nervous system to delay this urge appropriately. In overactive bladder, could altered central processing affect our ability to delay the urge when appropriate? So let's try and answer this question, does OAB belong in the category of central sensitization, by understanding the characteristics of conditions associated with central sensitization. So there's three main characteristics that need to be considered. The first, in central sensitization, you will often be able to identify comorbid conditions in your patient's presentation. So comorbidities such as IBS, endometriosis, idiopathic low back pain, fibromyalgia, migraine headaches are just a few of the conditions that have been highly correlated in the research with central pain mechanisms. OAB is often part of this cluster of syndromes and often precedes the presence of these other comorbidities. So that's characteristic one. Characteristic two is central sensitization coexists with psychological comorbidities. And the same is true for OAB. We see OAB and other psychological comorbidities existing together. These include depression, anxiety, stress, catastrophization, bipolar disorders, panic attacks, and post-traumatic stress disorder. The third characteristic is that OAB has been proposed to be a hypersensitivity disorder, just as bladder pain syndrome has been. Since allodynia and hypersensitivity are classic symptoms of central sensitization, this also helps us to understand how OAB can be partially explained by central sensitization, especially when the other two above characteristics are met. Qualitative sensory testing needs to further corroborate these findings, and the research is starting to look at QST in overactive bladder. Based on these three characteristics, OAB fits the criteria that we see in these pain conditions that are connected to central pain mechanisms. So since we do not have the ability to do qualitative sensory testing in our clinics, what are we going to use to measure the presence of central sensitization with our patients? Neblett et al. In 2013 demonstrated that you could use a questionnaire with good psychometric properties to identify the presence of central sensitization in the clinic. It has been my observation that many of my OAB patients have comorbid conditions as identified previously, as well as psychological comorbidities. These comorbidities are identified in Part B of the screening tool. So there's two parts to the screening tool, and we'll look at Part B in just a moment. In Part A, there's a list of characteristic questions that are asked to assess the presence of central sensitization. And if the patient score is greater than 40 on Part A, they are seen as having a sensitive nervous system. Part B then is a list of conditions dominated by central sensitization, and we've talked about some of them already. And so with this questionnaire, if they have less than 40 on Part A, but one or more positive conditions on Part B, they are also identified as being centrally sensitized. So it's an either or for Part A and B, not both. So there's been a plethora of research over the past 10 to 15 years, which demonstrates that a biopsychosocial approach is required when addressing symptoms associated with a sensitive nervous system. Assessing the bladder, the pelvic floor, and the low back is important and appropriate in lower urinary tract symptoms. So there's the bio component. However, assessing the psychological pieces as well as the context of a person's life is equally important in developing a well-rounded treatment plan if you seek to really ameliorate their symptoms, including urgency, frequency, and nocturia. So every patient is unique. If central urge mechanisms are involved, then assessing their psychological distress objectively is an important step to address the underlying factors that may be contributing to their overactive bladder. We measure objectively strength of their pelvic floor, tension or tenderness in their pelvic floor, bladder volume on urodynamic testing, frequency of urination on bladder diaries, and we do this with regularity with our patients because, again, we want to be very objective in assessing their presentation. However, when it comes to assessing yellow flags, we often use our intuition. But please recognize that when we use our intuition to guide treatment, it is affected by our biases and perceptions of the patient in front of us. So why don't we measure psychosocial distress objectively? I'm going to argue that we should, since it gives us specific targets to address, as well as the ability to objectively measure improvements or sometimes deterioration in the psychological factors that may be sensitizing their nervous system. So listed on this slide are all the constructs that I measure with every bladder patient with urge or pain, and the tools that I use as a physiotherapist to measure these constructs. So I look at depression, anxiety, and stress using the DASS-21. I look at catastrophization using the pain catastrophizing questionnaire, Tampa scale of kinesiophobia to look at fear of movement, low positive affect using the PANA scale, low self-efficacy using the pain self-efficacy questionnaire, injustice using the IEQ, and I also look at childhood trauma using the adverse childhood experience questionnaire. Insomnia is another component that's very important to measure, and I use the ISI in order to do that. So when you objectively measure or profile their unique sensitization, we can direct treatment more specifically at the area of distress and call upon an interdisciplinary team as appropriate. So let's look at this with our case study. Here's Barbara. Of course, Barbara's not her real name, but she is a real patient of mine. And of course, this is not a picture of Barbara either. However, the following is true. Barbara is a 59-year-old occupational therapist. She was recently divorced, bought her own house, and moved to an online charting system at work. Her stress, her self-reported stress, was significant. Her self-reported depression was also significant. She was still at work, but she was feeling completely overwhelmed. She was diagnosed with interstitial cystitis because of frequency during the day, which was 15 times on average per day and 5 times at night. And that was diagnosed 2 years ago, despite the fact that her cystoscopy at that time was normal. Recently, another urologist diagnosed her with overactive bladder because frequency and pressure were her main complaints more so than pain. The timing of her symptoms initiation about 2 years ago coincided with her marital dissolution. Interestingly as well, Barbara had just been started on Cymbalta 1 week before coming to see me, and so clearly her physician believed that she also had a sensitive nervous system, since Cymbalta is a classic medication used for central sensitization. Looking further at Barbara's subjective screening, her social components were as follows. She was not sexually active. She was not in a relationship. She had lost most of her friends in the divorce. They had taken sides, and unfortunately, she was feeling very isolated socially. She only had one son who lived 4 hours away. Her bowels were reported to be healthy. And when I looked objectively at her sensitization scores, her central sensitization inventory, part A was 44. So this puts her greater than 40. And part B, she did have one comorbid condition, which was migraine headaches. On further psychosocial screening, because she has a sensitive nervous system, these are the constructs that she scored positive on. Her self-reported stress was severe, rated at 27 on the DASS-21. Her self-reported depression was moderate, rated at 18. She had low positive affect on the PANA scale at 19, so we want to see that at 30 or above. And her catastrophization levels were just in the moderate category, so they weren't overly high. 20 is the cutoff for moderate catastrophization, and she was just above that. On physical examination, Barbara was very teary. She had a hard time focusing. She was very overwhelmed. And so the first session, we really just did a good history and did some education. The second session, I screened her low back and we did some more coaching and education. And again, there's another presentation at the conference that I talk about the connection between lower urinary tract symptoms and low back pain. And so I screened her low back. She had no directional preference. And so we did not need to address that bio component of her presentation. I didn't do her internal exam until the completion of her second visit because of her level of overwhelm. And at that time, she had suprapubic and abdominal allodynia, and allodynia is a classic sign of central sensitization. She had minimal obturator internus hyperalgesia or pressure hypersensitivity, again, classic central sensitization. She had no prolapse. She had normal strength of her pelvic floor, normal coordination of her pelvic floor. So after her initial examination or after the first visit or two, I like to actually sit down and draw this diagonal diagram with my patients so that they understand what we are going to do to address the symptoms at hand. And on the top left of the diagonal diagram, I always put the tissue issues or the peripheral mediators of the problem. And on the bottom right, we look at the central mediators or the sensitive nervous system. And so of all the peripheral mediators that she could present with, and this isn't an exhaustive list, but a list that most physiotherapists will look at, she really only had tension in her obturator internus muscle. On the other hand, if we look at the central mediators, she had pain and pressure for longer than 12 to 16 weeks. She had classic allodynia and hyperalgesia, and she had significant psychosocial factors. So when pain is dominating the picture, we will often do pain education to help patients understand the biology of their pain system. I have used a similar approach with overactive bladder patients, replacing the word pain with urge. However, the research is becoming clearer that high fear avoidance and high catastrophization are connected to a better clinical response to pain education. And Barbara's catastrophization was not all that high. It was just over the moderate threshold. So I actually did not do a lot of pain education with Barb. What I did do, though, is a lot of education that was condition specific. So we talked about the difference between IC and bladder pain syndrome and overactive bladder. And we discussed the fact that she actually fit better with the diagnosis of overactive bladder as per her second urologist as well. And I spent time on this so that I gave her high expectations of treatment outcome and resolution and hope that she could get better. So let's look at how treatment went. So in the first 3 visits for Barb, our initial target was really stress, since that was the highest component of distress for her. The prescription we talked about was using breathing exercises in a constructive rest position on her back with her legs up on the couch. While in this position, I had her listen to a meditation once a day that focused on relaxing her bladder. It was a very similar script to that Donna Carrico demonstrated in a 2008 pilot study that showed that 50% of 51 women with OAB and IC bladder pain syndrome resolved their symptoms with using meditation for calming bladder urgency for 15 minutes twice a day. Instead of having her do this meditation twice a day, I also had her do mini meditations on the toilet, as demonstrated by Shelley Prosco, a Canadian pelvic health PT, and she calls this meditation the airbag meditation. It's a short relaxation script for really letting go on the toilet and trusting her bladder to empty. Many of these women start to push to empty their bladder since they believe that their urgency and frequency is there because they're not emptying their bladder fully. And then to address the social component, I asked her to talk to her boss about her concerns about the online charting system and to get some help with this. We quickly started to incorporate strategies for her depression on visits 2 and 3. Her evidence-based options for depression were cardiovascular exercise, yoga, or resistance training. And these were prescriptions that, from a physiotherapy perspective, I could prescribe to help her with her depression. And she chose yoga. She started a short yoga practice once a day for 20 minutes, focusing on the hips, the pelvis, and the pelvic floor. So this yoga practice was designed to also release tension in these areas, but more importantly, to also calm down her central nervous system. And then last but not least, we addressed her low positive affect. And again, evidence-informed choices for low positive affect are cardiovascular exercise, gratitude training, meditation, and acts of paying it forward. So as not to overwhelm her, she chose to write down 3 things every morning that she was grateful for. So a very simple practice around gratitude, and committed to joining a local neighborhood group to start to get involved in her new community. Now, she could just as easily have chosen cardiovascular exercise, since it would also have hit the target of stress, depression, and low positive affect. However, she was feeling very overwhelmed and chose some quieter practices to start with. So at the 4-week mark, we redid her bladder diary. She was already noticing that she was going to the bathroom less often. And we started some deferment strategies to further bring about confidence and control. So again, bladder training strategies that we're all very comfortable with. So in 2 months, in over 5 visits, Barb reported being symptom-free. She had no more pressure, no more pain in her bladder. Her bladder diary showed that she was voiding once at night and 7 to 8 voids during the day. She had reconceptualized IC and bladder pain syndrome and recognized that it was more of an overactive bladder, coincided with significant distress around her divorce. Central sensitization inventory reduced nicely from 44, which was again above the cutoff of 40, to 34, which was now below. Her self-reported depression went from the moderate category down to the mild, self-reported stress from the severe category down to the mild. Her low positive affect was trending upwards from 19 to 26, and her target was 30 with that. And her catastrophization normalized from 22 down to 8. So in summary, when we're looking at treatment strategies for a sensitive nervous system, we have 3 steps that we want to consider. The first is, from a metaphorical perspective, is to extinguish the fire under the cup, or to desensitize the nervous system in a targeted way. So again, using measures to profile their nervous system and then targeting those measures with some evidence-informed practices. The second strategy is to really empty the cup or challenge the tissues again. Our goal in this strategy is to decrease the nociceptive drive, and in Barbara's case, we looked at that through time voiding or deferment strategies using her bladder diary. And then the third strategy is to really look at sustainable lifestyle changes that will help her over time to continue to manage her stress. And so she committed to doing a regular practice to evoke the relaxation response, and she stuck with her yoga practices. So when we look at Reynolds' proposal in 2016, the conclusion of their study indicated that an understanding of the pathophysiology and clinical manifestations of central sensitization in OAB could provide a novel approach to managing this condition. Such an approach would be especially relevant to those patients with central sensitization-related comorbidities and has the potential to improve the outcomes of these patients in particular. So the key messages that I want you to take home today are, first of all, to routinely screen for comorbidities in overactive bladder. Secondly, to screen for psychological comorbidities as well. And then to address those psychological comorbidities using a profiling and targeted approach for the sensitive nervous system. I want you to think about taking a whole person approach to overactive bladder using a biopsychosocial framework. And last, to build a team around yourself to help with the complexity of these patients, including a specialized physiotherapist, a psychologist, a gynecologist, and perhaps a sex therapist. Thank you for your attention, and please do not hesitate to reach out to me if you have any questions. Bye for now.